Maybe not motion.
Did you see the first one of this?
Yeah, I don't know what it is.
Yeah, everybody here? I'm going up for
All right. Bill, can you hear me?
Sure can.
So, sorry for the delay due to technical problems, but today we have coming from Hawaii, right? Which island are you on?
On Oahu.
Okay. Dr. Phil Verhoef. And this lecture today is part of our health and spiritual wellness series. And we're just delighted to have you back. Phil gave, for those of you who recall, gave a wonderful lecture for last year's Donuts and Theology. And we're just so pleased to have him back for another lecture. And he's going to talk today about the US healthcare system and caring for ourselves. So with that, Phil, we'll turn it over to you and thank you again for being here today.
Oh, it's my pleasure, and really great to be able to be there with you guys. Sad I can't be there in person, but we'll get things going. And it is about 6:30 in the morning here in Hawaii. As I said the last time, I'll be objective, but I will also be political. I think that healthcare is political. And I think if we choose to make it not so, I think we are sort of sticking our heads in the sand. But I'm hoping that you will find this sort of stimulating, and I certainly welcome any and all questions, particularly if you think I'm wrong. So at the last meeting in the spring, I talked a little bit about our healthcare system, describing it as a complex patchwork of multiple payers, private insurance, Medicare, Medicaid. It's driven by financial incentives and profiteering more than people's health. And I think that's the honest truth. I think it results in the worst outcomes of any developed nation by any measure, and leaves 27 million people without any health insurance. We also now have a gutted NIH and CDC, which is really crushing our capacity as a country to do research, to prevent disease, to manage outbreaks, to manage public health. And we also established that as Christians, we are called to care for everyone, particularly those on the margins of society. And so I would ask that question: how are we doing with that? How are we doing at caring for ourselves equitably so that everyone is free to explore their God-given gifts and understand how they can best make a difference in the world? This is a slide that I often present. It's an ironic slide, right? Because here, this is a photograph from 1937 of flood victims, African-American flood victims. And they were victims because the only neighborhoods that they had access to were the neighborhoods to live that were flood prone. Those were the only places that African-American folks could basically, they were segregated into those spaces. And so, of course, when a flood hit, they're the ones that are waiting in line for food supply, standing beneath a sign that says there's no way like the American way. So, I'm going to start with this somewhat complicated slide, but just to say, when we're thinking about health and our health or the health of people in our country, there are actually a lot of things that drive that. And over here, all the way on the right, is the healthcare system. And that's what I focus on as a physician. But there's all these other things that lead to people's health. There's food, right? Food security, or whether or not you have access to healthy food, as many people do not. There are this concept of the food desert, where there are no grocery stores or no grocery stores selling fresh food. There's education. Do you have access to good education, to vocational training, to higher education? There's economic stability. Can you get a job? Is the job that you get going to pay you enough to actually be, able to support yourself and your family? And heaven forbid you run into, medical bills, for instance. Of course, there's housing, right? I used to live on the south side of Chicago, and there were kids in the neighborhood near me that had no idea that there was a lake a mile away from them, because their housing, their neighborhood, was an unstable neighborhood, and they didn't feel safe going out of that neighborhood, right? And so all of these things actually play into our health. And I think it's important to keep that in mind. Unfortunately, these are all places where we might see discrimination and disparities. And I'll get into that a little bit today. But I think ultimately, this is sort of a spoiler, I think we need a safety net. That's my belief in this country that reflects our Christian values, one that can address a number of those problems. And I would also argue that the current administration is destroying that safety net. Now, again, I told you I'd be a little political. So, again, how are we doing at caring for ourselves equitably so that everyone is free to explore their gifts and understand how they can make a difference in the world? You might ask this a different way, saying, how are we doing at caring for our neighbor? How are we doing at doing unto others as we would have them do unto us? How are we doing at loving and treating all people as God's children? And so this is going to be the depressing part of the talk where we talk about all the ways that we're failing at that. And this is, this is maybe the biggest slide. I showed a slide about life expectancy the last time I was here. We're still doing poorly, right? Here we are in purple at the bottom. That's the US. This is Canada, Germany, France, and the UK. What I think is striking to me is that, even in the last 40 years, our life expectancy has dropped compared to these other countries. And here we are now somewhere close to where we were back in 2000 for our life expectancy. So it's dropping further behind. And so that's obviously bad, right? We are not doing well as a country. But if we break this down into some different racial subgroups, it's not affecting everyone the same. So everybody's had a decline in life expectancy, and this is just between 2 years. But it's hitting people that are often marginalized to a much greater extent. This is people that are Black, people that are Hispanic, people that are indigenous. So this is American Indian or Alaska Natives. They are losing years from their life on average to a much greater extent than some of the other populations are. And if we look at not just total mortality, but let's look at maternal mortality. This is crazy, right? 26 deaths per 100,000 live births in the United States when mothers give birth, compared to all of these other countries, much, much lower rates. So this is awful, right? We are not taking care of ourselves very well. But again, let's break that down by race a little bit. And you can see that for Black people who are giving birth, 55 deaths per 100,000 live births. Again, compare that to other countries. This is crazy, right? And then let's look at infant mortality. Our infant mortality numbers also dwarf everybody else. This is deaths in the first year of life per 1,000 births. Ours are far higher than these other developed countries. And again, let's break that down by ethnicity. And it's far worse if you're Black, if you're indigenous, if you're Native Hawaiian or Pacific Islander, compared to being white. And so, again, you ask, why are these disparities here, right? Why is there so much dramatic inequality in health outcomes in our country? Now, I've made the argument, and I won't get into this too much, that this has to do with not having health insurance. So these are the percentage of people that don't have insurance, broken down by race or ethnicity. So about 5% of white non-Hispanic folks don't have health insurance. But my goodness, look at this. Black, Hispanic, Native American. There's a lot of people that identify as those racial groups that don't have health insurance. And one of the things we know is that not having health insurance is deadly. In some fancy analysis some colleagues of mine did, we discovered that if you don't have health insurance, you're simply more likely to die. And this is not asking the question, why are you more likely to die? It's simply associating that when you don't have insurance, you are much more likely to not be able to survive within a given year. And so potentially 36,000, 40,000 excess deaths simply by not having health insurance. So then you ask, well, yeah, why is that? Why would health insurance be such a big deal? Well, remember that people of color are getting less care. This is the amount of money that we spend on people that are white. Around $8,000 per year is spent per white person in this country. Far less for people that are Black, Native American, Hispanic. Why? Because they don't have health insurance. They don't go to the doctor. They choose not to receive care because they're going to have to pay for it, right? If we look at healthcare spending by age, you can see that whites are in blue, Black in salmon, Hispanic in green, everybody else in purple. Again, at every age level, we're also seeing more money spent on healthcare for people that are white compared to all the other age group or racial groups. We also know that people that don't have insurance and people of color, they tend to have poor blood pressure control, as an example, right? So if you look at folks with private insurance or Medicare, who have good control of their blood pressure, first off, it's only about half of us, right? And so people take your blood pressure medicines. But if you look at people that don't have any insurance, much less likely to have their blood pressure controlled. If you look at people that identify as some of these other races or ethnicities, much less likely. And what does that mean? Well, we know as doctors that if you don't have good control of your blood pressure, we know that you're more likely to have a heart attack or a stroke. That's pretty well established data. So this is another way that you can imagine that these folks that don't have insurance also don't get medical care. We know that if you don't have if you're a minority, you're much less likely to have access to mental health. And this is just a slide that illustrates that. Psychiatrist visits per year per thousand population, much more likely to go to the psychiatrist or have access to them if you're white, you're much more likely if you're white compared to if you're black or Hispanic. We also know that people that don't have insurance are less likely to seek care when they're having a heart attack. This is literally, I'm having chest pain. I don't want to call the ambulance because I'm going to get the bill. And so not having insurance means you're going to make those kinds of decisions. And I think that that's really problematic. And now we could go on and on, right? We could talk about this, but it should be hopefully evident to you that if you don't have health insurance or if your insurance isn't very good, that's going to drive worse health outcomes. But there are other things that I think drive these worse health outcomes too, and I think one of them is income inequality. So the rich are getting richer and everybody else is not. And this is over about 70 years of data, you can see that the people in the top quintile of income, their income just keeps going up. Everybody else's is sort of staying kind of stable or not really going anywhere. And so you can see that disparity, that inequality is potentially a problem here. And if you look at the income of people that are black compared to people that are white, you think, we made all these great advances in the civil rights movement in the 60s, but still the income of the average black family is only about 70% of that for folks that are white. And one of the things we also have seen an association with is that the lower your income, the shorter your life. And this was a really interesting study where they looked at people who were in their 50s in 1992 and then asked the question, are they still alive in 2014? And looked at their incomes. And if you were in the poorest fifth of those folks, half of them were dead. If you were in the richest fifth, 3/4 of them were still alive. So I'm not going to propose that the solution is that we fix income inequality, but I'm going to identify that this seems to be a real problem, and I think it needs to be something that folks think about. What else is driving these outcomes? I think the infrastructure of our healthcare system drives these outcomes as well. And so this is an interesting one. If you look at hospitals that tend to serve people that are black, versus ones that that don't necessarily have that, those black serving hospitals have lower revenue. They also actually lose money compared to hospitals serving a more diverse population. And so you're literally seeing that those hospitals are not making as much money in those communities. We see that, and because of that, they tend to offer fewer of these services. They don't offer cardiac surgeries or bariatric surgeries or MRIs or PET CTs. So is it any wonder when the infrastructure is set up against them that people in these marginalized communities are less likely to have good health care? This is an example about how much we spend for our Native American population through the Indian Health Service. This is a system that the government set up decades ago to take care of Native Americans. We spend only about $3,300 per patient there compared to almost 3 times that for the national average for healthcare spending in this country, which basically means it's kind of a choice that our government has made that we don't actually care that much about those folks because we're not going to really fund to take care of them. There's also a concept that if you haven't heard of, you should learn more about, and that's called redlining. And this was this concept that between the 30s and 1968, people of color were not able to borrow money to buy properties. And so this is an example of a redlining map from New York City from a while back. And if there were properties in blue or green, those were neighborhoods that were inaccessible for people of color. And so that ends up de facto shunting people into these red areas where you can see that this is basically Harlem up here, right? And then lots of these other areas throughout the boroughs, right? And so that resulted in concentration of poverty, and that's never going to be a good thing. So, I think that there's infrastructure issues that drive inequalities. I think there's also workforce, at least for as far as healthcare is concerned. If you look at enrollment by Black minorities in U.S. medical schools, it's far less than the average number of people that are Black in this country. So that the goal is that we achieve about 11.7% enrollment of Black people in medical schools, but we're not getting anywhere near that. And unfortunately, it looks like we're actually starting to get a little bit worse. And that's a shame because one of the things we know is that if you're a Black man, you're more likely to follow a Black doctor's advice. And they actually did a randomized control study about that. They liked their doctors just fine, but they were a lot more likely to follow the advice of somebody that looks like them. And so obviously to help healthcare for people that are in a minoritized population, perhaps the best thing that we can do is have them see somebody that looks like them. Unfortunately, we tend to see concentration of people that are Black in these lower paying parts of the healthcare system. So again, the workforce average, 12% of people are Black, but they tend to be overrepresented in the lower income, lower tier jobs within the healthcare workforce. We actually see the same thing with people that are Hispanic. Actually, there's 16% of our workforce is Hispanic. And again, they're more likely to be concentrated over here as medical assistants or aides compared to being actually physicians. We could spend a long time talking about income inequality, and we're not going to spend much time on that. But rest assured, both females make less than males, but also if you're Black, you make less as well. And it's hard to wrap your head around this because why should this actually be? And yet it is the case. I'll skip the next slide because that one takes a little bit to talk about. So I would argue that we're doing a terrible job of equitably assuring that everyone has access to health. There are disparities in insurance coverage, there's disparities in income, there's disparities in infrastructure, there's disparities in our workforce. And I think there's many other factors too that we didn't really have time to get into. And that brings me back to this slide, this concept of social and economic factors driving health outcomes. What I hope to have just shown you is that we are not equitably caring for everyone. Our healthcare system is discriminatory, and I would argue that a good safety net needs to think about all of these kinds of concepts if we are to truly be able to help everyone. And so this is I think one of the things that is our call, because I think everyone deserves humanity, deserves dignity. And so, what is the solution? I think that that's complicated, but I think, again, that we need a safety net that reflects Christian values. And we don't have such a safety net right now. We're watching that safety net be destroyed through the massive cuts to Medicaid and Medicare, which will unquestionably lead to an increase in uninsurance, and that's going to lead to people's deaths. But it will also lead to more medical bankruptcy, right? We are seeing that the current administration is crafting work requirements and administrative burdens for people that are in Medicaid. It's kind of funny. People have estimated the amount of administrative burden to do all the work requirement will actually cost more than providing health care for the people that are in Medicaid, because it's going to create this administrative beast, which is terrible, right? The premium tax credits on ACA plans, that is something that was in the news these last couple of months, and so that's going to certainly hurt folks whose health insurance premiums are going to go up substantially. We've seen the destruction of the NIH and the CDC, and I think that's, as me personally, I have been an NIH-funded researcher for a long time, and it's just a shame that this is going away. My wife, who's in public health, literally worked for the CDC, and the vast majority of people she worked with are now gone. They don't work at the CDC anymore because they've all been fired or they've resigned. And I think that this is a really dangerous precedent for taking care of everybody in this country. There's the end of affirmative action policies in higher education. There are these attempts to dismantle food assistance and Social Security that I think are coming as well. And it's funny, when you say, what's the solution? And you say, I'm not seeing any good solutions. Here's the legislator here. And here's, of course, the people that are sort of spewing money at them to say such things. And so I'm going to just focus on what I think the solution is for healthcare. And I think it is that we eliminate the private insurance industry middleman. Because remember that private insurance industry only exists to make money anyhow, and that we replace it with a national government administered insurance program for everybody. This is sometimes called Medicare for all. You can say, no, that's crazy. Why would we do Medicare for all? Is Medicare really any better? Remember, Medicare came out in the 60s under the Truman administration, actually. And I would argue that Medicare has the fewest barriers to care for people, that it's efficient, and that it's really effective. And so Medicare has the broadest national network. When we did a survey, or Kaiser Family Foundation did a survey of docs that accept Medicare, 90% of physicians accept Medicare. So that's pretty good. There's no insurance company that 90% of physicians actually accept. And if you're a surgeon, almost all of them accept Medicare. And so, that's a broad network of doctors that already accept this plan. But perhaps more importantly, it means we're not going to waste so much money. So this is the insurance overhead numbers for the top 5 health insurance companies in this country. And what this means is that for Cigna, 18 cents of every dollar that they receive in revenue, they keep and call that either profit, or that's overhead to keep the lights on, or overhead to pay people to deny care or to create administrative burdens, right? When we compare that to Medicare, and Medicare is really efficient. 98 cents of every dollar actually goes to taking care of people, because Medicare doesn't have really any drive to make money or to engage in things like prior authorization or denying care. So it's a super efficient way to actually take care of people's healthcare bills. And when we look at growth in spending over time, we can see that, with commercial insurance, spending in healthcare has increased by over 50% in this 10-year period. But if you look at Medicare spending, it increases by a much lower rate. And that means that is helping us not spend so much, helping keep healthcare costs from going up so fast. But this next slide is perhaps my favorite one of all of these. People are healthier. And so you can see on the bottom here, this is age, and it's in little 5-year increments here. And then our rank in terms of our life expectancy compared to 16 other countries. And so you can see that, like I'd mentioned at the beginning, we're pretty much way lower than everybody else in terms of our life expectancy compared to many other countries. We rank 17th or 16th. But then when we turn 65, a funny thing happens. Our life expectancy goes way up to become number 1 by the time you're into your 80s. And so what happens? Does something magically happen when people turn 65? The only thing that magically happens when they turn 65 is they all get health insurance. Everybody in the United States gets health insurance by the time they turn 65. And lo and behold, getting health insurance means you can get health care, and all of a sudden our outcomes get so much better. now the cynical other way to look at this is that, well, so many people have already died that the people that are left we're selecting for the folks that are more resilient. But I don't think that's actually the case. And so this is why I really advocate for this solution of improving Medicare so that it covers everything, so that you don't have to buy these supplemental plans, you don't have to buy an Advantage plan, you'd get all of these benefits covered: mental health, drugs, inpatient, outpatient care, dental, hearing, long-term care. You wouldn't have to pay copays or deductibles or premiums. It would be funded through our taxes. You wouldn't need to buy additional insurance, and it would be much simpler for physicians rather than having to deal with all these different health insurance companies. And so I think that this is possible, and this is what we've been fighting for. We wouldn't leave anybody out in this system. It would include everybody in the United States. Oh, not the people that are immigrants. We talked a little bit about this last time. People that are immigrants are not the people that drive healthcare costs in this country. In fact, they pay into the system but use very little services. You'd be covered for your whole life. You wouldn't have to worry about your pre-existing conditions, and you could choose whatever doctor or hospital you want to go to. Now, you're like, there's no way that this is going to happen. But in fact, the economics do play out. So there have been 29 studies that suggest that the amount we would save by using a system like this would fund all of those benefits. In fact, a large number of economists have really been pushing for this. And even the Congressional Budget Office said, look, we can affordably do all of this, expand benefits and eliminate cost sharing, and it will still cost less than what we are currently doing in this country. And so, if you compare us and Canada, and I'm not going to say that Canada has a perfect healthcare system, but they do have a national health insurance system that covers everyone. In 1971, we were similar countries. We had a similar GDP, similar life expectancies. We signed the HMO Act into law in 1973, creating HMOs, whereas Canada, they implemented a Medicare for all type of system. And if you look at healthcare spending as a percentage of GDP, we passed the HMO Act, but that didn't really change anything for our healthcare spending. It didn't constrain costs or spending at all. Canada, again, we were the same right up until about 1970, but they implemented their Medicare system, their national health insurance program, and now they spend less than half that we do on healthcare. And like I showed earlier, their outcomes are much better. Their people live longer, they have more access to care, which is a pretty striking difference with us. And so ultimately, we spend so much more. This is like a hidden tax, right? That, to have this private health insurance system that we have in this country, we're paying $2,400 more per person compared to Canada. It just doesn't make a lot of sense to me. So, people sort of say, gosh, how can we make such good things happen? Well, this was just from, just from a couple of weeks ago. I was in Washington, D.C. at a rally at the Capitol, advocating for improving healthcare in this country. And so, obviously that's one way that one can get out there. But I think there's a lot of other things that you can do, right? If you're interested in this as a solution, you can talk to your legislators about it. There are bills for this. I think it's important to tell your healthcare story. I think everybody has one. Everybody has a story where the healthcare system in the United States has not served them well, whether it's because they've gotten bills that they didn't expect, or they weren't able to get the medicines that they expected, or they know someone who suddenly had to change insurances and could no longer afford therapies. There are stories out there. And I think one of the things that we're realizing is that everybody has a story. And that if we all kind of get together and share them, we'll realize that this system isn't set up for success. It's set up to make money for a very small number of people. And I think that's really problematic. I think teaching other people is important. I think many people don't understand how our health system works, and they don't know how to fix it. And that's the sort of thing that I spend a lot of my time thinking about. And then I think recognize that this kind of injustice that we have in this country, the fact that our health, that we're not taking care of everyone equally, that injustice plays a crucial role in driving the broader inequities that we see. And I think if you can bring that perspective, I think that's helpful too. And obviously this is, there are all these organizations out there that are fighting for healthcare for everyone. And so it's very much something that is near and dear to my heart. And so, obviously you're welcome to work with any of these kinds of organizations. We very much believe in the mantra of everybody in and nobody out. But I also like to tell people that there are alternatives to this, and I give people references if they'd like to find out what that looks like. But, I think in the interest of time, I'd like to hear some questions, and I'll turn my slides off now. Just to sort of say, I want to come back to where we began, which is that, I think that, if we're thinking about taking care of ourselves, to me, taking care of ourselves really means taking care of everyone. It's not just taking care of me as the individual, it's how do we take care of everybody? And I think that that's part of our calling. And I think part of that is that we create a healthcare system that reflects our values. Well, what do we value? We value each other. We value everyone. We value people being able to figure out who they are. We value people caring for each other. And I think that the system that we have right now doesn't facilitate that very, very well. So I think we need a system, whether it's a healthcare system or a social safety net, that takes care of people that for reasons that relate to the way our society is constructed aren't really able to take care of themselves. And so I think that this is a time where we're seeing many of these things that we thought were pillars of our safety net, whether it's the healthcare system or, again, the research or, food benefits. Many of these things are under attack. And I think it's an opportunity to stand up and say, look, what is the Christian solution to this? It's not to be exclusive. It's not to pad the pockets of insurance companies. It's to take care of each other. And to me, taking care of each other means creating that robust safety net that reflects the values that we have. So it's 10 after, and I don't want to keep you too much longer, but I'm happy to field some questions if you've got any about all of the stuff that I've just talked about. And I welcome your challenges or your thoughts, anything along those lines. So thank you.
Phil, I don't know if you remember me from last year. I'm fairly forgettable, but you might we had talked and I made some comments. First of all, wonderful talk. There was not any point you made that I think any caring person with any sense of justice could dispute. And I think you might know I'm a retired physician. I was an internal medicine physician. Just a couple of comments and a question. Part of the problem for what's going on is the death of primary care. I do believe that. Primary care is twisting in the wind, dying a small death. And a lot of the things that go to promoting longevity happen in primary care, not to blow my own horn. There's a lot of great specialists that do a lot of great things. And it's almost as important as what we did in primary care. But the essential problem is capitalism. Now, I'm a capitalist, and to paraphrase what somebody said once, it's the worst economic system except for any other economic system. And I tend to agree with that. Healthcare should not be capitalistic based. Healthcare should not be a money-making industry. It should be, as you described, Medicare for all, getting an essential service to people. And as you touched on, healthcare debt is the #1 cause of bankruptcy in the United States. I mean, a guy has a daughter who's 17 and needs a root canal, and he's got to take out a second mortgage. I mean, it's insane. Yeah. So just to preface that, and I'll stop talking, I'm sure you'll be grateful. My question is, in the Medicare for all, do you envision, first of all, I think it would have to be a tiered system, almost like current Medicare, where wealthier people pay an IRMA of some type, an extra fee, because the wealthy should pay more. for premium. The other question I had is, do you envision there needing to be some kind of pre-certification just because the technology is so rapidly advancing and the costs with this technology is so rapidly advancing?
What do you mean by that?
Well, right now, if you have commercial insurance and you want to get an MRI, you have to get it pre.
Yep.
I understand Medicare is starting to move a little bit toward pre-certs for certain things that are being abused.
Yeah.
In a Medicare for all system, do you envision there being some level of pre-certification, which of course will add to the administrative burden?
Yeah, I think you're raising a few really good questions. So I agree with you about the death of primary care, and I think that's because we've set up a healthcare system that doesn't value primary care, and there's a lot of different historic reasons for that. If you listen to podcasts, you should listen to one called Not Otherwise Specified, where the podcast host is taking apart why primary care is falling apart. And she's interviewing thought leaders on this. I found it really compelling. But, we as a society or as a medical establishment have not valued primary care, and therefore primary care makes the least amount of money. Nobody wants to go into it. And the burden of work is insane for your regular primary care doctor. And I do think, and when we look to other countries with universal healthcare systems, their primary care docs are not at the bottom of the totem pole. They are much more respected. They make a better wage. There's not this income disparity where the neurosurgeon makes $2 million a year and the primary care doc makes $200,000 a year. So I couldn't agree more. And a bedrock of a good healthcare system would be a big primary care system. Now, when you're asking about pre-certification or how do we constrain, you're really asking, how do we keep people from ordering an MRI for every single person? And I believe that the vast majority of doctors just want to do the right thing for patients. And if we don't have evidence that getting an MRI for every single person is a beneficial thing, then we're not going to do it. I think one of the problems is that decision making in medicine now often asks the question, well, is this going to make me more money or not? Right. And that's not right, because that comes back to the point you made that there shouldn't be sort of this notion of profit. What we should be driven by in our decision making is, what does the evidence tell us is the best thing to do? We have people doing all of this research telling us, when should we be screening for colon cancer? We've now moved that to the age of 45 when you should get your colonoscopy. That decision was made based on lots of research that we did on the benefit of screening people for colonoscopy at 45 versus 50, or people talk about screening for breast cancer, right? Those are all decisions that doctors make because of the research that gets done in these fields. And so that's the thing that should be driving our decision making. Now, will there be some mechanistic way of constraining use? There probably has to be something. But I think that if we actually take all of this stuff out of the way and just let doctors make the decisions that are in the best interest of people's health, I think in the end, you're going to have much less overall use. And like, how many times have you had to get a CT scan and then you had to go to a different doctor and they couldn't see that CT scan, so you just got another CT scan? We see this happen all the time because we can't communicate very well with each other. If we create a system that's actually patient-centered and health-centered, where we have more free exchange of data and information, we're not going to need to continue to get all of these kinds of imaging or things like that. So, you're really asking the question, how do we keep overuse from happening? And I think that overuse will go away when we actually have a system that works more efficiently and effectively. The other slightly cynical part of me says, look, I'd rather there be overuse than underuse, because we know when there's underuse, the people die. Right. So I'd rather people be getting more than less. But I'm not saying I want things to go crazy and everybody get an MRI every week or anything like that. But the part of me that wants to see people do well and be healthy would prefer that they get health care than not. Because right now we've created a lot of barriers for people to get health care, and I don't like that. I think that's problematic. And in fact, those barriers themselves are inequitable. It's much harder if you're of a minoritized population to get the health care that you need. I like that question, though. Thank you.
So following on your comment, I've heard stories about doctors economically benefiting from sending patients to MRIs because they work in a facility where that's the case, or they own shares in a company where that's offered. How prevalent is that?
Oh, so that's absolutely true. It's hard. I don't know that I can easily put a number on the prevalence of that, but one of the things I'll say is that it used to be that you could be a doctor and you'd hang up your shingle and start your primary care practice, and you could work with a couple of other people and have a small practice, and that works fine. There are fewer and fewer small practices like that anymore. Most of your doctors now are salaried and working for big health systems. So you guys have Atlantic out there, right? And that's a big health system that salaries people rather than has them sort of out, doing things the way things were done in the past. And I think under those kinds of larger employed arrangements, it's harder for doctors to make money, on the side by owning the radiology department, owning the suite that makes the MRI machine and happens to be also in your building. So, I think that that's out there. I don't know that it's hugely prevalent, but I also think it's getting harder to do that as these large corporate healthcare systems grow. It's interesting. I sometimes show a slide about how CVS owns, CVS is a drugstore, but they also own an insurance company, one of the biggest ones in the country. They own the pharmacy. They own the pharmacy benefit manager, and they employ literally thousands of physicians. You have this single company that has captured vertically all of the different parts of the healthcare system because they can find ways to optimize their ability to make money there. So I think that's a bigger problem, the way that the corporations are figuring out how to profit rather than doctors as individuals.
One more question. This is my last. So when you read stories about the healthcare system in England, it's a national healthcare system.
Yep, national healthcare system. Yep.
And you read stories about people in long lines waiting for service, or there's a private industry that provides these kinds of services to those who are willing to pay. And of course, the conclusion people draw from is the standard of care for us all will decline to some mean level, which we don't want. I don't believe that, but I'm wondering if you have something to say about that.
So I think one of the reasons that's happening in England is that and I don't know how we make people make better choices, but right now the government is underfunding their National Health Service. And because it's underfunded, they don't have enough doctors, they don't have enough facilities. It creates a market for private insurance to come in and try and fill in that niche. It's like, if we are going to do this, we have to actually do it right and not constantly starve that system, right? So I think that that's a huge problem. I think it's kind of funny to me, though, I will say that there are these perceptions, but then when you look at the data, people in the UK still live longer than we do, and they spend less money on their healthcare than we do, and their health outcomes are better than ours. So in spite of that perception, the data are suggestive that it's still a really strong system. And I guess the last thing that I would say is, it's, for better or worse, it's somewhat intentional that this proposed solution is a government-run insurance, not in the UK, all of the doctors are employees of the federal government, and all of the hospitals are owned by the government. And that's not really the solution that I'm talking about. I'm just talking about simplifying the way that healthcare is paid for in this country. So My hope would be that it would be less subject to some of that as well. That if we simply are willing to fund the insurance program to take care of everyone, you can still start your own practice. You can still have private hospitals. You can still have private physicians out there. You're not going to have, it's just simply they're getting paid through this government-based insurance, which is really quite effective in a number of other countries. But yeah, that concern is a real one. I guess the last thing I'll say about that is there was a study that looked at care at the Canadian United States border, and they to sort of ask the question: are Canadians sort of flocking to the United States to get health care? And there really is no evidence that that's the case. In fact, more Americans are going to Canada to get healthcare because it's easier to get medications. Sometimes it's easier to get appointments. When people are trying to use that system. So I don't think that's. I don't think that we're seeing lots of Canadians coming to the United States. There's obviously going to be a few, but their system largely is working pretty well for them.
Bill, I want to thank you very much on behalf of all of us here at PCM. I want to thank you for getting up at the crack of dawn to give us this lecture, and we're so appreciative. I want to encourage you to keep up the good fight, and I'm going to join your organization, which hopefully won't bring it down. But
We're always looking for more people in the fight.
I very much respect what you're trying to do, and I think we'll get there if for no other reason than the train we're on right now. It's a slow ticking bomb.
Yeah,
it's unaffordable, and people are paying $30,000 a year for insurance for a family of four, making
crazy.
So thank you for enlightening us, and thank you for your presentation. And same time next year.
Oh, you got it. I'll be here. Thank you all so much. Always a pleasure. And, be nice to my parents.